Right, I think we're gonna start. So welcome everybody. Welcome to the 2020 series of free webinars sponsored by the Canadian Association for Suicide Prevention, the Quebec Association for Suicide Prevention, and the Center for Research and Intervention on Suicide, Ethical Issues, and End-of-Life Practices at the Université du Québec à Montréal. These are the dates when we initially had planned for a national conference on suicide prevention to be held at the Université du Québec à Montréal in Montreal, Quebec. Because of COVID-19, that event has been rescheduled for October 27th to 29th, 2021 in Montreal, with pre-conference activities being held on the 26th of October 2021. Please mark that in your calendars and look at the websites of CASP, AQPS, CRISE for further information about this major national event. I am Cécile Bardon. I'm professor here at the University of Quebec in Montreal at the Psychology Department, and I'm Associated Director of CRISE. Today, I have the pleasure to introducing Monique Séguin and William Affleck, who will be doing today's talk. Monique Séguin is Professor of Psychology at the Université du Québec en Outaouais and a researcher at the McGill Group on Suicide Studies at Douglas Mental Health University Institute since its foundation. She's also a researcher with the Quebec Network on Suicide Research, Depression, and other comorbid disorders. William Affleck holds a PhD in Social and Transcultural Psychiatry from McGill University. Currently, he's doing a postdoctoral research at the Université du Québec en Outaouais, where he undertakes research on suicide amongst Inuits of Nunavik. They will be speaking for about 40 minutes, and then we will be having a 20 minutes period for questions and discussion. It's very important that if you have any question for the presenter, you write them in a chat function of the Zoom meeting. You can find it at the bottom of your screen. Presenters will not be directly reading the questions since they spend their time concentrating on their presentation. However, I will be reading the questions, and at the end of the presentation, I will select the questions to ask the presenters. The total time for the presentation and question period will be an hour, and we should be finished no later than 5 minutes after the hour. All the presentations are being recorded, and you will be able to access them some weeks from now on the website of the three organizers with an S, sorry, CASP, AQPS, and CRISE. So without further ado, I'm passing the mic onto William and Monique, and please enjoy yourself, and thank you very much for being here.
Thank you, Cécile, for this nice presentation, and I'd like to thank William for joining me doing this conference, and hello to all of you, and thank you for being here on a nice Friday afternoon. At least it's very nice where I am. So I'll do a screen sharing right now. Okay, so with my research group, we did a study on suicide death in Nunavik from January 2014 to December 2018. So I'm presenting today with William Affleck, but at the end of the presentation, there's going to be a list of people who participated in this study, and there are many of them. So I thank them from the start. Okay, so the objective of this study, first of all, this study was commissioned by the Nunavik Regional Board of Health and Social Science and Social Services, and the objective were, there were 4 objectives. First, to map the life trajectory of individuals who died as a result of suicide in Nunavik between 2014 to 2018. Then to compare this group to a second group of individuals who have made a suicide attempt during their lifetime, and to compare them to a third group from the general population who have never made a suicide attempt. Another objective was to involve participants and people from the community to participate in this research, and in doing so, promote, motivate knowledge transfer. And finally, the last objective was with our partners, with mental health professionals, to plan to make recommendations for suicide prevention to the Nunavik Regional Board. So the recruitment strategies were determined in collaboration with the Nunavik Regional Board and a numbers of groups, such as the Inuit values and practitioners, the suicide prevention workers, the community liaison and wellness workers, mayors from different communities where we were going, and we had a steering committee which was with us from the beginning to the end of the study. Of course, when we started the study, we arrived with a proposal of a study we were accustomed to do. In the discussion with all these groups, a number of concerns, real concerns, especially in regards to recruitment and interview process, were raised. So we with all these different preoccupations, we adapted the methodology to respond to some of these concerns. For example, the data collection about the deceased people, not all, but most of them, was primarily based on coroner's report, medical files, because our partner were afraid to re-traumatize people who were already vulnerable. Another example is the use of long structured questionnaire on mental health, like the SCID, which raised a lot of negative feedback from our partners as they felt it was not in line with the narrative cultures of Inuit. So as we had proposed, we took a few instruments out, but we used a narrative interview on life trajectory using a calendar design to collect all possible events that the participant had encountered throughout his lifetime. So we carried out a semi-structured narrative approach along a chronological axis from birth to current time. During the interview process, a sheet of paper is used to draw a circle, which you can see down there or something like that, to draw a circle which represents specific time during the participant's life and is used as a memory anchor. Predefined sphere of life were discussed. For example, parent-child relationship, early adverse events, academic and or professional event, affective spousal relationship, procreation, and the participants' own family events, social life, losses, living condition, and personal adversity. So when the interview was finished, each interviewer drafted a clinical vignette, which was submitted to a panel of expert raters. The raters were asked to integrate for each period of life a score, which is a summary variable corresponding to the total burden of adversity. This score ranges from 1 to 6. So 1 means having low protection, high adversity. So life is not going very well when the score is 1. And to 6, high protection, low adversity. So the expert rated each trajectory independently before the consensus discussion. And after the consensus discussion, well, the statistical analysis take place, and statistical analysis computed trajectories. So at the end of the study, we could compare 3 groups. The first group of 63 individuals who have died after a suicide, 85% of them were men. Second group of 23 individuals who attempted suicide, 70% of them were women. And a third group of 47 individuals who never attempted suicide, 70% of them were women. So for group one, in some occasion, we met with the bereaved family themselves. But for group 2 and 3, we met directly with participants. And when they had a medical file, with their authorization, we reviewed the medical file as well. So for the results, there was an evolution of suicide rate, an important evolution of suicide rate during the period of the study. For example, from 2014 to 2018, the rates was 300% higher. In 2014, 11% had died after a suicide, in result of suicide. And in 2018, 34 had died as a result of suicide. So there was an important increase in mortality, especially among young men. 60% of the deceased were under 20 years, and a higher rate in larger communities. So the figure here is the survival curve, and illustrates the age at which people died. We observe a rapid curve of suicide death. Of the 63 people who have died, 60% died before the age of 19. 10% died between 20 and 24, as you can see. And again, 10% died between the age of 25 and 30. A great number of risk and protective factors were identified throughout this life course trajectory. As expected, results revealed that people who have never attempted suicide had more protective factors in their lives than those who died after a suicide. Results indicate that there was an important variable. There had a lot of risk factors, but most important of them were being victim of early adversity, having had early academic difficulties, dropping out of school very early in age, being bullied. And by being bullied here, we need to understand that it's not only in school, but in a number of social contexts, in school, out of school, social situation, in media context. So it's an important violent environment when it starts and happens to some individual. As well, suicide, substance abuse was another important variable, aggressive behavior, and spousal conflict. So as you can see in the table here, and I know it's a small table and I won't go through all the results, I'll just give you the big picture. So individuals were rapidly exposed to early adversity just by the fact that parents use or had substance abuse. It creates a difficult environment. And then people were exposed to family difficulties such as conflict, tension, rejection, negligence, violence, being exposed to domestic violence, difficulties in living conditions, being victim of bullying, social violence, academics, spousal difficulty, etc., etc. So I won't go through all the different data because it could be because of time constraint. But for those who would like to have more information, the research report is available. So at the end of our talk, we will stay on the last slide. My email is on the last slide, so you can just write me and I'll send the report to you. You just tell me if you want the report in French or in English. So as for the mental health problems as well, the difficulties associated is much more substance misuse are very significant, mostly alcohol drugs. And as we can see from alcohol drug misuse lifetime and current, overconsumption of alcohol or drugs occur early in the life course of the individuals for all three groups and appear to be persistent for many years, even decades. At the current time in the suicide attempt group, people reported less current misuse, but still you can see, especially for the suicide group, as it is extremely high. Besides substance abuse, a mood problem is reported by individual of the three groups, and it's between 15 and 70% depending on the groups. And the other problem is conduct or externalized problems. Another interesting and important data is on number of suicide in the immediate family. Individuals in the three groups have been affected and exposed by suicide in their family or in their social circle. It's important to consider this data because the death of a loved one after suicide generates grief, but that may sometimes have a traumatic related element, or that may develop into complicated grief and induce other types of psychological problems such as depression, substance misuse, or for adolescent and younger adult that may have an identification dimension on the person who have died after suicide and create more and more suicide in different communities. So we get now to this, to the burden of adversity. So this figure represents the burden of adversity trajectory for each group. The horizontal line represents the age of participant, and the vertical axis represents the burden of adversity. So 1 at the lower part of the screen, when there's a 1, life is not very good. Very high adversity and low protection. And a 6 is low adversity and high protection. So what we see in the red, the figure shows that the three groups have the same type of level adversity at the start of their life. So under 4. But the trajectory in red, as you can see, representing the burden of adversity of those who have died as a result of suicide, reveals a burden that is present from the beginning of life and that increases throughout life compared to the trajectory of the two other groups. So life becomes more and more difficult, and you can see that there's a steep curve up to 20, 24, 25, 29 years old. Then there's the increase, but the increase is just statistical difficulty because there's less and less people in that group as time goes by. The trajectory in blue is that of the people who had made a suicide attempt, represent a life course whose adversity is high from the beginning of life and remains stable until the age of 15 to 19, but then increases in the 20s. So it's as if they're able to find themselves some protection, sometimes by leaving the household, having their own living houses, having a family, having, especially for women, have children, creates some protection, at least for some period of time. While This was the, I'm sorry, we don't, I was mistaken. I said the blue one, but I was talking about the green one. So the green one is people who have made suicide attempts. So you see they are stable until the age of 15, 19, and then adversity for them comes more. As for the blue one, the blue is people who have made no suicide attempt. And this is interesting because we see difficulties in the beginning of life and then a decrease in subsequent years. Sometimes this adversity in the beginning of life is due to environmental difficulty, and many of these people were living with parents who had who had alcohol and drug misuse and were a bit violent. So they were taken in. A lot of them had protection from their families, their grandparents, and they were taking in. And as the protection, and we see the protection going up throughout the rest of their lives, and the protection comes from more stable and positive environment. So this figure here correspond to path analysis according to outcome of life trajectories for the three groups. So it's a model, and it tried to tease out specific variable which could explain one or the other trajectory. So the results indicate that substance abuse is directly associated with the group of people who have committed suicide. So you see the red line there, which has a high value. While bullying is associated with people who have made a suicide attempt and those who have never made a suicide attempt, orange and blue line. In the same figure, we observe that when substance abuse in parents is associated with the presence of violence very early on in age, thus causing adversity or important adversity for the child, the environment seems to respond by offering more protection to that child, taking in a child, adopting a child, which can mitigate the burden of adversity and prevent suicide and mortality. So this trajectory is more associated to the group of suicide attempt. So in summary, the life trajectory data indicate that the cycle of adversity, which involve early family violence and social violence, such as long-lasting bullying. And I insist here that it's not just something that happens a few months in a school year. It's bullying at school, outside of school, throughout social environment, through social media. And it becomes to be a very negative environment from which these young people cannot escape because they live in very small communities and they can't escape from it. And a number of young men or young women told us during the interviews that sometimes when they were victim of this, they felt that they were living in a social hell. So it's an important variable to consider, and it creates difficulty and creates sometimes the substance misuse, particularly alcohol, which is a distal and proximal risk factor for suicide. Results from this study found that substance misuse starts very early in life, and a number of people reporting overconsumption increased with age and contribute to violence between spouses, family conflicts, and aggressiveness. And toward the weeks or months before a suicide attempt, these adversity seems to generate feeling of rejection, distress, loneliness, and create a feeling of not belonging to a social group, and feeds into becoming a burden. So we all know as as Joiner's interpersonal theory of suicide tells us that the feeling of being a burden and feeling of not belonging are strong indicators for suicide. So I will now give the mic to William. While we were doing this research in Nunavik, William was working with us on this research, but was doing a research of his own. So he will tell you about his research, and then we will conclude with the recommendation that we made, stemming from both our researchers and discussion with participants and mental health providers up north. We will discuss the recommendation that we submitted to the Nunavik Regional Board. So William?
Okay, thank you very much, Monique. Can everyone hear me okay? Okay, fantastic. So as Monique said, I was part of this study up in Nunavik, and I was lucky enough to be conducting many of the interviews that took place. So although the study itself was a quantitative study, because we did long depth, open-ended interviews, there were a number of themes that kind of naturally emerged from the interviews that have allowed us to go ahead with the qualitative analysis. So there was specifically two topics that participants wanted to talk about that came up repeatedly again and again. The first was the high rate of suicide amongst young boys and men. Lots of people talked about this, but in particular, health workers, frontline health workers talked about this. And the majority of these, not the majority, all of these frontline health workers were female. So the female frontline health workers wanted to talk about what was going on with young boys and men. The second topic that came up had to do with help-seeking behavior. So many cases after a suicide attempt was made, the participant did not go to seek any kind of mental health support or talk to a counselor or anyone within the kind of structure that was provided for that reason. So participants wanted to talk a lot about this as well, why they didn't go to see mental health services. So two articles are currently in the works. The study design used a secondary qualitative design, so that because the project itself was not looking at these two themes, a secondary analysis lets us go back in and pull the data out of the interviews that were already conducted. And thematic analysis was used to analyze the data. Oh, sorry, Monique, that's you. Okay, thank you. So for the first topic, what's happening with boys and young men? There were 5 major themes that participants talked about. The first had to do with the intergenerational impact of the dog slaughter. So for those who don't know, the dog slaughter was a major traumatic event in Inuit history. It was in the 1950s and 60s when the RCMP went through to each community and systematically killed the sled dogs. It's a very complicated and sad story. But what the dog slaughter did is it completely humiliated and emasculated men who relied on dogs for hunting and for travel and for everything. Kind of their male identity was wrapped in very intricately with their sled dogs. So when the sled dogs were killed, they couldn't work, they couldn't provide for their families, they couldn't travel, they lost physical activity, so became physically unwell and emotionally unwell. So that happened in the 1950s and 60s, but participants talked a lot about the intergenerational effect of the dog slaughter, particularly for young men. So there was 2 mechanisms that came up a lot. The first was participants talked about how the dog slaughter had changed Inuit ideas of masculinity. How before the dog slaughter, what it meant to be a man was built on contribution and productivity and being a good hunter. And after that major event where the men were so emasculated and humiliated, what it meant to be a man switched to how much you could drink. It normalized violence. All sorts of unhealthy elements entered into Inuit masculinity that have therefore been, or since then rather, been passed down from generation to generation. The second main idea out of this theme was had to do with childhood trauma. So the men of that generation who were so emasculated became very angry, self-loathing, and drank a lot to cope with their humiliation, who then turned into more physical and emotional abuse, and also sexual abuse against children. And lots of participants talked about how this was a way of reasserting their masculine dominance, was by sexually abusing children, but in particular young boys. And again, that was this physical, emotional, and sexual violence became normalized and has been passed down as well. So the second major theme that came out was the change in the economy that's taken place. Lots of participants talked about the transition from traditional life to modern life and how it's been difficult for all Inuit, but it's been particularly difficult for young men. And one of the major reasons for this rather, is the changes in economy, that where the economy used to be based on hunting and trapping and guiding, kind of physical, masculine centered jobs. But the new economy has changed now to more white collar office based economy, mostly with government and with NGOs and things like that. And that men, because young men tend to drop out of school much earlier, they don't meet the requirements, the hiring requirements for these jobs. And they also lack the computer skills and the technical skills for these jobs as well. So with the loss of these jobs, men have also lost their provider roles, and it's been really challenging for men in that regard. Participants also talked about the barriers that have set up to hunting. So it's become more and more difficult for men to hunt. There were two reasons for this. The first is that they spoke of the conflict in schedules. So hunting, for example, requires lots of time on the land. It follows migration patterns and seasons and ice conditions, all sorts of things that are out of sync with modern society, which runs on a 9 to 5 weekday, weekend schedule. So what modern society has done is it's forced many men into a situation where you either exist and succeed as a traditional Inuit man, which means a hunter, or you exist in the modern economy, in the modern world, and there's very little overlap. So it forces men to choose, which people found was, or discussed how that was a real barrier. Another big barrier to hunting came from the increased cost of equipment. So participants talked a lot about how in previous generations, most men had access to hunting equipment. So things like sled dogs and hunting rifles, and this was available to most men. But now with the modern economy and how things have become so material, hunting equipment, you now require a boat, you require a cabin, you require a truck, and there's all sorts of specialized equipment that, because that is so expensive, leaves it out of the reach of many men, particularly young men, as like teenagers and unemployed men as well. So the third theme had to do with gender norms and gender roles. Many participants talked about how men simply would not talk about what's distressing them. And that has to do with Inuit masculinity, which is quite traditional. So any expression of emotional vulnerability or distress is is viewed negatively and is often case punished. So what this does is that it forces young men to hide their grief. So this is a theme that came up a lot, is you never know that young men are suffering, because when you talk to them, they're smiling and they're laughing and they're going to great efforts to hide the fact that they're struggling. And then on account of that, they don't get the help they need, either professionally or from their families. And it comes as a great surprise when the suicide takes place, because no one knew that they were in trouble. So this was a theme that came up a lot. And then finally, there was also institutional factors that came up in the interviews, that people talked about how young men were overlooked and how they were made invisible. So one of the central institutional factors was social housing. So in Nunavik, as in most of the north, housing is provided by the government. And because it's provided by the government, but it's based on need. And because young men, without kids at least, are typically is not viewed as a vulnerable population, they're the lowest on the housing list. So that means that there's far more young homeless men than any other population. And this ties into things like unemployment and homelessness and lack of agency and all sorts of things that contribute to the suicide crisis in young men. Participants also talked about youth programs. So in many of the small communities, youth programs are run at the school or through the school. That's where young people will come to socialize, but also the means through which support staff can monitor them. So when you come to the youth center, I can see how you're doing, which is all fine and good when you're in school. But if you leave school, like many young men do, then it's very easy for young men to fall through the cracks and to not be monitored. So that came up again as well. In most of the communities, actually, that came up as a big issue. Finally, there was also lots of suggestion for what could be done to help young men. So on the macro level, one of the major themes was that Nunavik needs more physical blue-collar jobs. People thought that the trades would be more accessible to young men who tend to leave school early, and would also keep them outside and being physical, which lots of participants felt would be very beneficial, both physically for their physical health and also for their mental health. And the second thing was targeted mental health programs. So lots of participants talked about how the mental health services that are up there, even though they're gender neutral and they're available to men, they're not really targeted or suited towards young men. So they thought that what they needed was more targeted services, specifically services that brought in more men's activities. So things like skidooing and hunting. And also they thought that these programs should be run by older men from the community. They thought that young guys needed an older mentor to help them through this stuff. And that should be the ideal person to lead these programs. In fact, a lot of people talked about, interestingly, that the mental health care needed to be snuck in. So they didn't think that the young men would go to mental health services. What they would go to is a skidoo club or a hunting club or a woodworking operation, which you could then kind of sneak the mental health care into through the back door maybe. So those were the suggestions. So that's basically the suggestions for the first theme, which was the young men, the first topic. Thanks, Monique. The second had to do with the suicide help-seeking behavior. So why weren't people going to see support workers or suicide counselors after an attempt or when they were in trouble? So there's three themes that emerged from the study. The first had to do with a deep mistrust of mental health workers. So a lot of people talked about, questioned what was going to happen to their data. There was lots of, why do they want to know that? There's lots of great mistrust. There was also a lot of mistrust around the motivations of the mental health care workers. A lot of people talked about how they were just up here to pay off their student loans, and they're just up here to get a down payment for a house, and they don't really care about us and that kind of thing. So there's lots of suspicion against the workers themselves. There was also interesting resentment against the system, which was very generalized. So people talked a lot about vacation packages for white people, for example. They didn't think it was fair that white workers got more vacation time than local Inuit workers. Same thing with houses. There was resentment that white workers got a nicer quality of house. White workers also oftentimes, especially in the bigger communities, will have their cars flown up for them. So this wasn't necessarily specific towards mental health care itself, but this was the rationale for not going to seek help, was there was a kind of a resentment of the system that will get worked out as the analysis goes further. one more point about that, the resentment of the system. A lot of people talked about how they felt like second-class citizens in their own community. And mental health care was a representation of this. And then finally, the third theme had to do with past experiences that they've had with the mental health care system. Either they've had or one of their friends has had or a colleague has had. People talked a lot about the change and the turnover a lot, where mental health care workers will come up for 2 or 3 months and then leave again. So when you go to see one person, you explain your story and everything like that, you have to go again and you have to start from scratch and get another white Southern face who's there for 3 months. And people felt very disconnected, like this wasn't working. And it also tied into the resentment of theme 2. People also talked about racism, how they've gone in the past for after a suicide attempt or for mental health care, and they're blamed a lot for drinking too much or all these things that come along with systemic racism. And then finally, there was lots of talk of what they call the white room, which is a kind of an emergency measure. So when someone's in acute suicidal distress, they get put, usually by the RCMP, into a padded white room where they're left for 24 hours. And a lot of people felt that was extremely humiliating and they would never want to go through that again. So these are the qualitative themes that are coming out from the project. The analysis is still being done on this, so nothing's written up yet. But when it is, I look forward to sharing it. And maybe actually next year you can come by. I can come back again and present the work. Okay, so it was a bit of a digression into the qualitative analysis, but now we can go back into the recommendations from the study. So the first has to do with respondents' recommendations. So in terms of the needs for the population at large, a lot of participants brought up the need to counter social isolation. I'm just going to minimize this. Social isolation, particularly of adolescents and of men. That came up a lot in the interviews. They also commonly suggested creating men's groups. We've already talked about this. So same thing on the concern for the individual and family level in terms of what the participants recommended. They thought there needed to be more intervention for substance abuse, particularly alcohol abuse and dependence. And they also needed many more anti-bullying measures. So those are the big things from the participants. In terms of mental health professionals' recommendations, in order to look at groups, again, mental health care workers suggested increased services for adolescents and also for men. They suggested more treatment centers for substance abuse, including sobering centers where people could go to sober up for 24 hours or whatever it needed to take. And also crisis centers. So each community should have an acute crisis center where people who are in real trouble can go to last minute. In terms of populations as a whole, the health workers suggested more programs to foster social connectivity and also to strengthen the social network, kind of the social fabric. They also suggested more specialized psychoeducation and mental health programs. So mental health promotion. So for example, a lot of people talked about the need for programs explaining historical trauma and the impact it has on mental health, and also the dangers of substance misuse. So to wrap up, looking at the quantitative study and also the recommendations from the participants, the research team suggested to the regional board who commissioned the study that they undertake a multimodal strategy that focused on alcohol, substance misuse, and also bullying. So a multimodal strategy, for those who don't know, is a strategy that targets different groups simultaneously. So in order to target the general population, we suggested that they have programs again that increase social connectivity and a sense of belonging. They also should increase information about mental health services, access to mental health services, and also acceptability. They should work on people's attitudes towards mental health services. In terms of vulnerable groups, for example, victims of bullying or violence or substance abuse, we suggested anti-bullying services or programs be set up, especially in schools. And we also suggested, again, that focus should be on increasing access to addiction and mental health services, and also increasing positive attitudes towards these services. And then finally, for high-risk individuals, we suggested that every community should have specialized mental health services, and also that the model of delivery for these services should be broadened. So right now, mental health services exist, and it's up to individuals when they do exist, because in many communities they don't exist. But when they do exist, it's the idea that the individual should come to the center. And we suggest that, in fact, it should get broader than that, where there should be home visits, follow-up, not necessarily from mental health professionals, but from people from the community could do it as well, and more individual outreach. Okay. So
okay.
those are the recommendations.
This is a list of people who would like to acknowledge and thank for their participation. And I will leave with this. So if any of you want to have the research report, you can send me an email and I'll send it back. Thank you so much. Thank you, William. And thank you
very much
for your attention.
Thank you very, very much for this fascinating and worrying set of studies that that brings me a question about the scope of what there is to do. And from what you said, they decided to concentrate on two topics that were alcohol use and bullying. Who made that decision? Was it the steering committee, or was it where did that recommendation come from?
Well, it was stemmed from the results, and of course, you know, we could have suggested to work on early adversity, which would change trajectory, would benefit and change trajectory. But this is working on health determinant. And working on determinant of health is a perfect objective, but at the same time, it's a longer process. It's a program that needs a lot of investment for a long, long time. So discussing all of this with our partners, we targeted more variable that has an impact, especially starting early in young age or at the adolescence. So working more on social violence and alcohol drug misuse, which are programs like William was expressing that could be tucked in to a lot of environment and a lot of places. So it was our recommendation. People agreed. Now the board is now working on a suicide prevention strategy. So I will see what eventually they decide to do. But the last decision was not ours to take.
Yeah, thank you. There is a question of details that popped up. For the police part, is it RCMP or KRPF that's involved? Because the participant said that Nunavik does not have RCMP normally. So is it the RCMP or KRPF?
Well, it would be the, excuse me for the confusion, that would be the local police.
So
I'd probably use the RCMP as a shorthand, but it would be the local police.
So it was the local police. Okay. Another question is, do you have any suggestions to decrease the barriers, the one brought forward by the young man in the community, such as the mistrust and the resentment? Let me rephrase that. I just read it and didn't. Right. The young man you interviewed brought up the fact that in the communities there was lot of mistrust and resentment. Do you have suggestions on how to decrease those mistrust and resentment within the community from those young men?
Maybe I'll give a first answer, and Will, you can help me with that. But I think that we're giving intervention should be more given at a community level. So doing more outreach work, going more to work in the community with people, helping them get the jobs or the mental health jobs eventually. I think that would eventually change some of these barriers that we see right now. Yeah.
Yeah, that makes sense. I also think that, excuse me, there could be more community outreach. I think that right now it's kind of siloed. The two worlds are siloed. So I think that there could be much more trust built by the mental health care system in the community.
Yeah, there is a question / comment in the Q&A section where somebody was asking, would there be a way to give training to Inuit people so that they can be part of the social services instead of just being, recipients? And you touched a bit upon that issue as well. And do you know if there are programs or incentives to increase participation of Inuit in the caring community, basically?
Because we all know the paths to social misfortune, I would say, or to social isolation, and we all know the mechanisms of these paths, and we see them at work in every society. So it's not specific to the northern communities. But in the northern communities, there are smaller groups. They are more isolated or entangled together. And those who are on these paths of cumulative adversity, it goes very fast, very fast, and very negatively, very rapidly. As opposed to in other communities where you can change environment, where you can change places more, you can change group in a bigger city, for example. So what is important here is for these young people who have problem in school, who to whom they're made fun of because they have problem in school. They are bullied very early. So they live with violence, and sometimes inside their house, even if it's not directed toward them specifically, but sometimes they live with tension in the family, and they live with violence sometimes outside, some of them, not all, but some of them outside the family. So these young people, they drop out of school earlier. So they're very, they're on a pathway to some kind of failure. So I think these pathways could be changed by, keep organizing school differently. And I remember a participant told us, it's strange that we have schools now, we've been having schools now for 46, since the 1960s in Nunavik, and still we haven't graduated a lawyer or a doctor. How come there is no, there's not a lot of possibility to continue schooling? So I think that mental health, of course, is a pathway, but education is another pathway. And I think it's very important for these two big trajectory to kind of work together much more than we see it now. And I'm not speaking just for the northern societies, but maybe it's more evident up there. William, if you want to add something, just...
Okay, I will. I actually lost track of what the question was. Maybe you can repeat the question. Hello?
Cecile?
Sorry, I muted myself.
Oh, okay.
The overall arching question was about how can we integrate Inuit youth and adults into the healthcare system so that they're not just recipients but also providers of healthcare.
Right. I think that there's definitely some focus on that at Arctic College in Nunavik. I know that there's lots of talk of starting a mental health care program. I know that there's nursing already, and there is a module on mental health nursing. So I think that there's efforts to be made to bring to foster more Inuit mental health workers. But of course, it ties into many barriers that are set up.
Yeah, definitely. Let me just go through. Yeah, some people wrote quite a long sentences, but somebody is asking. I know it's probably hard to access information due to the confidential aspects, but is it planned to study the situation when someone didn't attempt suicide but was hospitalized or multiple times hospitalized for suicidal ideations? Well, they would constitute another group to be compared, I imagine, like somebody who's had many ideation and was hospitalized for that. Do you think you could have access to this kind of populations to add another level of comparison, I suppose?
Yes. Well, you know, it's another challenge methodologically, because what we did, when we went to different communities, we recruited participants. So everybody who was interested in participating. So it was just after the interview that people were assigned to either group of people who have made a suicide attempt, compared to those who had never made a suicide attempt. So if you want to distinguish a third group, maybe those who had severe thoughts of suicide, severe ideation, who might have been hospitalized but never made an attempt. So it's another group, and it multiplies the challenges of recruitment, because people were very concerned of not stigmatizing anyone. So that's why when we did the recruitment, it was a recruitment at large, and the assignment of people in groups were made only after the interview. We did ask mental health workers to try to identify in their caseloads people who had these vulnerabilities, but it seemed to be extremely delicate and difficult.
Okay.
So yes, everything is possible, but you know, in doing a research like this, there's always a lot of challenges, and it's what would be interesting to do and what is possible to do. So you have kind of to organize a give and take, and
yeah, especially in smaller communities where everybody knows what everything is happening around, and confidentiality may be more difficult to keep. Somebody gave an information. There is a program for Inuit workers to become social assistants. It's done by Marie-Victoria Cégep, and it's a training job with a diploma at the end. So there are programs. Cégep Marie-Victoria, I think it's in Montreal, isn't it?
yes.
And they do a program like that. Somebody's asking a question about money and budget. For a moment, Health Board injected much more money on youth protection. By example, in a community, they hired 3 YP, so I suppose YP social workers. Is that young people social workers?
Youth protection workers, I think.
Youth protection social workers, sorry about that, against 0.5 social workers for youth program in CLSC prevention programs, I suppose, in the south of Quebec. Is there a will to have recommendations about budget on preventive programs in the north?
Yes.
The money question.
You know, it's a small study, and I know you know it's we made some recommendation, but at the same time it's difficult to do to tackle every problem in one study. So we made specific recommendation on some strategies that could be embedded, you know, tucked in different communities, hoping, you know, that for a first level that it could work. But as for the budget, you know, it's kind of outside my my pay grade.
Area of influence. Somebody's brought a precision in. Marie-Victorin are sending teachers to Nunavik, usually to train people up there. So, well, before the COVID.
There are efforts, which which is occurring, and that's great. I was just saying that these efforts are perfect. They're great, and hopefully there'll be more and more efforts like that. Yeah,
definitely. We have time for final comments, and I'm allowing myself to make it. You use, I think it was William, you used a very interesting phrase. You said we have to sneak in mental health into other activities, and to me that resonated very much with the caring community concept. Yeah. That it's not just care for people is not the mandate of professionals belonging to the healthcare community, but it's a mandate of the community to care for its people. Basically, and the caring community approach. To me, I had flashes of that when I was hearing you talk about the way elders can be involved, or older men can be involved in training younger men and everything, you know, and sneaking in mental health care. To me, that was the cherry on the sundae of that, that analogy. So very nice. Thank you very much for your presentation and for your work, which is, as we all know, very much needed. And I hope you can come back next year with more comprehensive results on your qualitative study. That's great, William. And thank you very much, Monique, also for your contribution to this topic. And thank you very much for all those who were present here today with us. I wish you a very pleasant weekend and a nice autumn and winter. Monique, William, if you want to stay with me for a few minutes and not leave straight away, we're going to say goodbye to everybody. And there is a last webinar within 30 minutes. So for those who are registered, you can switch rooms, and otherwise have a safe day and a nice weekend. Bye, everyone.
Thank you. Bye-bye.
Thank you very much.